OsteoSignal, Episode 13. This is OsteoSignal with Neal D, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Okay, welcome back to OsteoSignal podcast with Neal O'Neill. And I have with me today Autumn Mayberry and Britt Mayberry.
Hello.
Hey.
How you guys doing today?
Great. It was good to see you last week.
Yes, it was fun being down in the Salt Lake area. It was very dry, very cold, but refreshing. And you guys don't have any snow. It's really too bad.
No.
Okay, so have you ever wondered why your body stands the way that it does? Why you walk with a certain rhythm? Why an old injury still seems to echo years later? Your body isn't broken, it's adapted. At OsteoSignal, we understand that movement isn't just muscles and joints. It's a conversation between your structure, your nervous system, and your internal physiology. When those signals lose adaptability, pain, stiffness, and fatigue appear. In this podcast, you'll learn how posture forms, how walking reveals hidden strain patterns, and how restoring small, forgotten motions can completely change how your body feels. This is not about chasing symptoms. It's about restoring adaptability. So welcome to OsteoSignal podcast, where we help you understand how your body moves so you can thrive in life. Okay, so the title today, Why Your Body Moves the Way It Does, Posture, Walking, and Adaptive Patterns. And so, of course, this is information for patients in general. We want to educate the public about just what it is we do and how we look at the world to help them demand more of their healthcare and be able to attain more. When people have problems in their life, they're often told, well, just don't stop doing that activity or stop living your life or stop doing this, that, or the other. And so, of course, no prior anatomy knowledge is required. We're going to explain this to you. And we hope to educate you to just make you better consumers of healthcare and demand more of your healthcare providers and maybe know better where to go look for what it is you really need. I mean, that's a key piece of this.
Yeah, if you understand what your body's really doing, then you can find the appropriate key to match that lock, right?
Yeah, exactly. Yeah.
Yeah.
And that's just it, is that part of it is everyone is so concerned with like a primary injury or the primary site of pain. And there's a real problem with that because, for example, one thing is a lot of people say, well, I didn't do anything to that area. It just started hurting, which ought to tell you if you didn't have direct trauma there. Now, one of the things we see all the time is where people did have direct trauma. It was just a long time ago. And they go, yes, but that was years ago. And I always point out that time is a magnifying agent, not a minimizing agent. So maybe initially you have that acute onset of problem and then that resolves, but the chronic dysfunction and problem continues to grow over time. And then it also connects to other injuries and other problems going on in your body. So then all of a sudden you have this big ball of dysfunction and you're going, no, but that was years ago. So that's certainly part of it.
Still in there.
It's still in there.
Bigger and worse than ever.
Bigger, badder, and yeah, exactly. More problematic. Okay.
In the military, we would call those second order effects.
Yes.
So
second order
things
effects.
that, kind of a cascade
Right.
from an original event.
Exactly. Those cascades that years and years later, now you have this huge problem on your hands. And how do you fix that problem? Well, as with all cascades, you have to go back to the beginning and understand that. And you need healthcare practitioners, healthcare people in your life who understand that and can go back and ask those questions and get you back to what are your initial causes, not what are your secondary causes. So I did want to kind of throw this at everyone. Have you ever wondered why you walk the way you do? Why one shoulder always sits higher? Why an old injury still affects your posture years later? Your body isn't broken, it's adapted. Today, I'll show you how your posture, walking style, and movement history shape your body's adaptive patterns and how we restore healthier motion. So
Makes me want to sit up a little taller.
Yeah, exactly. Make sure my posture's right here.
Yeah.
Can't talk about this without that.
Yeah.
Okay, so the core idea here is that the body moves by falling and catching itself. Okay, so your body doesn't move forward by pushing forward. It moves by controlling, falling, and catching, which is maybe a different way of looking at it than most people think. They think, no, I push myself forward and walking. It's like, no, you're using gravity to basically cause yourself to fall and then catch yourself. Now, efficient movement means falling smoothly, catching yourself with minimal effort, and then transmitting those forces back and forth so there's an efficiency to it. So when this happens, walking feels easy, standing feels effortless, joints stay healthier longer. You don't have back pain or foot pain or this, that, the other, or later have an aching hip. So from an OsteoSignal perspective, efficient movement depends on how the body falls and how often it can be caught using the least energy. Okay? So the three signals of movement health, right? And OsteoSignal is all about reading signals and understanding what signals mean so that we can get the full message, right? So that's the whole idea behind OsteoSignal, that there's information out there, but you still have to put it together. But in order to put it together, we need the general public to be educated into what are those signals. So every movement depends on three interconnected systems: the biomechanical, the bioelectrical, and the biochemical. So the biomechanical, joints, posture, load transfer. Bioelectrical, your nervous system, obviously, timing and coordination. Biochemical, tissue health, inflammatory situations, and the recovery from those. Okay. So dynamic equilibrium across biomechanical, bioelectrical, and biochemical signals determines movement efficiency. Okay, so and what happens if one of those signals loses adaptability? The others compensate. And over time, you have pain, stiffness, and fatigue. And that's where patients come in to see us, right, Autumn? I mean, they come in, they
Yes.
have pain or stiffness, fatigue, or they go, I don't know, this wears out. Or this pain comes back every so often, and then I have to like not do anything for a while. And
If I had to guess, I would say that's probably the most common complaint, right? Of the people who come and see you is that kind of stiffness or just
right,
general
right,
malaise. I'm
right. Like
tired all the
yeah,
time, or
everybody comes in and says, I think I need a new mattress. It's like, because when I lay down, this starts hurting, right? There's a reason that there's so much money in the mattress industry, right? It's like, because people have to
It's
constantly go
true.
through those, going, not this one, not this one, and
Yep.
money back guarantee. And it's like, yeah, but who goes through the trouble all the time? We'll put that in the guest room. So,
Hey, Neal. So when we talked about some of the stuff in class this last weekend, and I think one thing that was really helpful for me to just remember, but also what you cleared up with everybody in the class is what's the difference between adapted and compensated?
so
Because
yeah, that's yeah.
the medical community kind of throws those terms around, and they're not always really careful about how they do it. So maybe if we could make sure that we're really tight with how we explain it, and so people know what we're saying, then that will, because these themes are going to carry on through the rest of the podcast that we do, right? So
Of
maybe
course.
that would be helpful to educate people on what's compensated versus adapted versus
Okay.
adapted.
So there's
Yeah.
actually three levels there. It's kind of a hidden thing. So let's take that out. When you're younger or more mobile, you're adaptive, right? Like you're walking along and your body moves side to side, and you have lots of motion to make up for. Oh, I stepped on a rock, no problem. Oh, I have to step over a step, no problem. I have lots of motion available to me. I'm adaptable. And then over time, you have some injury, like we talked about, and something gets stiff and it stops working as well. And now you're always adapting to that problem. And pretty soon your body becomes adapted. It actually kind of gets stuck in that position, right? So you'll have your primary, let's say you have a foot problem, but then you start walking oddly. And pretty soon your low back, your hip is high on the side that you have the foot problem. Like you stepped on a rock and it hardened up your foot. And then you walk to try and avoid that, and it really jams up your whole back. So you were adaptable. You stopped being adaptable and you become adapted, right? You've adapted and you're stuck. You're stuck at the highest point of the adaptation. Now, if that sits there long enough, years often, you become compensated. Now you've broken something down. For example, I have an L3-4 disc herniation. That's a compensation. You have now compensated because you lost adaptability, because you went from adaptable, adapted, compensated. And that's a progression. And oftentimes, of course, the doctor's like, well, we'll go take out that compensated. We'll cut that out. We'll cut the disc out. And that's successful about 50% of the time, but it also leads to other problems.
at least other adaptations,
Right. Other
right?
adaptations, other places in the body. So then, like you were kind of pointing out, Brent, that you said, well, there's a primary problem and there's a secondary cascade. Then there's a tertiary, right, a third order, and a quaternary, right, a fourth order. There are, and then your body, of course, adapts up and down and up and down. And pretty soon people have neck pain and might have headaches because they walked funny on that foot when they, stepped on that rock so long ago, and that caused their back to go off, and then their neck is just, and then they're going, geez, why I get these headaches at the base of my skull? So you see these multiple orders of these things happening.
Is there a definite boundary between adapted and compensated, or like how do you determine where you cross over?
Yeah, usually the compensated is something the doctor can see on a test. Sometimes people
Oh,
go in and they
okay.
say, I have this problem. And the doctor says, let's do an MRI. Right? There's obviously a process there, but they go to the MRI and they say, yeah, we don't see any reason for you to have back pain. They don't see a compensation. They don't see that it's compensated. What they see is they're like, well, it must just be adapted. Now, they don't say it that way. That would be useful. They may not even fully understand it that way. They're going, man, looks perfectly okay to me. There's nothing we can cut to make it better. And so there is a difference between compensated, frank pathology, broken, and adapted. Now, that the issue is, though, that while there might be a nidus, like a central part of compensated, there's a penumbra, right? An area around that is still adapted. So you
Gotcha.
still have some adaptive on the edges, adapted, compensated, right? And that compensated part would be the part that they might do something about. But for example, in rotator cuff surgery, people say, I don't want that. It takes a year to get over. It's horrible. It's terrible. Right. Because they go in and take care of the compensated portion, the rotator cuff tear, the this, that, the other. But the loss of motion and the stiffness because of that then causes them more adaptation, more loss of adaptation, and they become more compensated, and that their shoulder takes forever to get back if it ever comes back. So people really
Right.
try to avoid that, right?
Mhm.
So that's really what we're talking about is like anytime you have these three layers of adaptable, adapted, compensated, and you go in and you have to cut through the first two to get to the compensated, well, then anything that was adaptable is now it's way out here. It's so far away that it's now instead of you're lacking this much adaptability on either side of that, and you've got a compensation that's this big instead of just that big. So there's a problem with what level are we at, and from our point of view, it's like, look, if we can make you adaptable again, right? There's the compensated part, there's the adapted part. If we can make that adapted part adaptable, so we take this lack of motion and then bring that motion all the way back in right up against the dysfunction or the pathology, then you might not even spend enough time on that pathology for it to irritate you that much. So we give
Cool.
people a way of moving around the compensation or the frank pathology.
Now, are compensations reversible without external intervention? Does manual therapy have a set of tools that can help with something like that?
We can minimize, but we can't. Once it's frank pathology, once it's broken, it's broken. But
I see.
amazingly, your body is amazing. Is if you build adaptability around that, and at these primary, secondary, tertiary, quaternary levels throughout the body never has to spend so much time there. That compensation. I mean, people have things that are kind of breaking down all the time. I mean, aging is breaking down, and so we see older people who are doing just fine. So the body is amazing at, I mean, kind of the way that it's built to break down gradually in a very specific way. As long as it breaks down evenly, those compensations don't mean nearly as much. So there are plenty of people walking around with rotator cuff tears that they could care less because they have adaptability still. And those are the people we work on. So yeah, we can't really fix the broken part, but it becomes almost like not nearly as important.
Sure. It
And that's
doesn't
the
really
goal.
affect your quality of life.
Exactly.
You can still really thrive.
Exactly. Survive, thrive, enjoy, right? All those good things. That it's like, look, that's what we all want out of life, that quality of life. What we would say is quality of life. So, I mean, that's a great question, right? Because people do go, oh, well, can't you just fix it? It's like, well, there's some things you can't fix, but do you have to fix it is the question we ask. And then even like taking that a step further, sometimes the doctor does have to go in. But if we make the doctor's job this big, right, the size of a
Mhm.
quarter instead of the size of a 50-cent piece or even something larger, the smaller we make the doctor's job, the easier it is for them to narrow in on what it is they need to do, the less invasive procedure they can use, the more effective that procedure will be, and the greater return to function on top of that.
Yeah,
So,
absolutely.
yeah, it doesn't have to be the end of the world. I mean,
Yeah.
yeah, we have people get total hips and total knees all the time, and then they go back and get back to all their activities. They're going, "This is great. This is awesome. Why didn't I do this
Mhm.
sooner?"
And that's what makes all the difference, right? Is that we bring that adaptability back in. So even if they do have to have something cut, we're like, well, but you can function afterwards. You can heal better. That rotator cuff surgery doesn't have to take a year to get better. You know, and then you have to go globally too, right? We have like the 3 concentric circles here, but then we've got, the compensations that you made at the feet as opposed to the head or in the back and stuff. And so we're always trying to treat those and minimize that. So yeah, that's why sometimes the compensations don't affect the person that much. And if they do, then they can come back a little bit better. So we're always trying to keep it from getting compensated, but treat the adaptation and make them adaptable again.
Yeah, exactly. I mean, that's really the idea there. So
what's the key to having that dynamic equilibrium that you were talking about?
So the dynamic equilibrium is really, or adaptability, really is having adaptability, biomechanically, bioelectrically, and biochemically. And if you have that adaptability, the key to that adaptability, I should say, is what's called postural adaptation or minor motion, right? So you have to have minor motion available to you. And when minor motion is lost, one area becomes stiff, another becomes overly mobile or hypermobile, tends to hurt. And that's when compensation and breakdown begins. So really the term we want to give that is postural adaptation. Postural is not a static position. It's a living adaptation, right? You should be able to move through and among and around something. And it's when something just becomes stuck and they are always moving on that pattern. And that's usually because of lost minor motion.
Can you maybe elaborate on what minor motion is? Is minor motion just kind of small changes in your posture that keeps you adaptable? Is that?
Yes, exactly.
Yeah. Okay.
Minor motion, and let's like pick a joint. There are the major motions that occur at a joint. And so, for example, like flexion or extension or side bending or rotation, those are major motions. But then kind of hidden down at a much smaller level, a joint has to be able to squirt around and have room to take the most advantageous route to flexion or extension. So, for example, if your hip can't flex or can't extend, but if the hip could kind of slide into a new position, it may be able to attain a more full range of motion. And so those minor motions are that ability to squirt left or right or to slide here or there, and then gain
or
that
wobble
major
yeah.
wobble. Wobble's a great
Yeah.
term for it.
Yeah.
So I've heard the term like mobility thrown around. Is that kind of the same thing? If your joint has good mobility, then it has, proper minor motion, or is that something different?
Well, like Autumn alluded to earlier, there's a lot of terms that are kind of thrown around with poor
Yeah.
distinction as to their meaning. Mobility tends to mean gross motor motion.
Okay.
And minor,
like range of motion.
like range of motion, like, oh, my mobility, can I get up out of a chair? Well, you can't get out of a chair if your knees can't, if your feet can't slide back, if you can't bend your ankle, bend your knee, bend your hip, then you can't get up out of the chair. You have to I don't have any mobility, I can't get up, I need someone to lift me, right? So
minor motion is within, I guess a structure that, like you said, allows it to take the most efficient course of movement.
And think about that, being able to, for example, this example is if a person has a hard time when they go to get up, if they can just do a little sliding, like my joints can just gently move a little bit, my minor motion allows me to get my center of gravity out over my feet, over my base of support, and now I can sit up. But if someone doesn't have that minor motion and they're kind of stuck, so of course they've now lost major motion, and they're like, oh, my center of gravity is behind me and I can't get my hips under me. I can't use my strength. See, so you see how that minor motion occurs at many levels to all come together to allow that major motion. So we can talk about a specific joint or multiple joints over an area and say, oh, can my spine get that little kind of move it sideways, slide this way, slide that way, and get and you see people when they go to lean forward, they might have to wobble side to side, but they get their weight over their feet and their feet push up, and then pretty soon they've risen. And that's one of the things we mean by mobility, but we have to take that minor motion back down to that, mobility within each joint, but also over a number of joints so they can work together to attain a goal.
Sure.
Does that answer that question?
Yeah, it does. Yeah. Thanks.
Okay. Well, and that kind of leads us into the body's internal plumb line, right? Your gravitational center. The body continually tries to keep a vertical gravitational line from the head to the feet. When that line shifts forward or backward, like I said, like this or like that, predictable mechanical and organ effects occur, right? So the body continually attempts to maintain a vertical gravitational line from head to foot, and then takes advantage of that gravitational line, saying, well, I need to rise. So I'm going, if I want to just sit here and not spend a lot of energy, it's a vertical line. But as soon as I want to rise up, I take that line and put it in front of my base of support, and then I have my momentum to take me up. Now, one of the problems, though, is particularly, like, say, people standing, people at rest, right? So let's consider that set of circumstances where somebody says, if I sit too long, I have pain, or if I stand too long, I can't go to a museum, or I can't go shopping with my spouse because then I just have too much back pain. So if the weight tends to shift too far forward, they have an increased lower abdominal wall tension, right? So there's too much pressure into their abdominal wall. Their neck arches more, right? Their knees lock backwards. Their feet will collapse inward in order to keep their balance, right? They start collapsing in on themselves. And then, surprisingly, there'll be excess pressure on the bladder and the pelvic structures, and they'll get more strain. Well, as people get older, or they've had babies, or this, that, the other, sometimes people start to leak. And this is one of the reasons. And of course, we're giving them all sorts of medications, or we're looking at surgeries to fix that area, when really it's everything but that area that's causing it. It's their postural adaptation. Okay? So anterior gravitational shift increases abdominal wall pressure, knee hyperextension, midfoot collapse, right? So people who have plantar fasciitis or sore calves all the time, sore feet, and susceptibility to urinary irritation. Not a good deal. Okay. Now, what if we consider the opposite? What if the weight shifts backwards for people, too far backwards? The pressure shifts onto the abdominal organs themselves. The upper back flattens, right? They become a little more rigid in the upper back. The weight falls into their heels, and you see these people, they'll be standing there and they're lifting their toes, and you're kind of going, oh gosh, that person doesn't have any weight in their toes. But the other problem with that is their shock absorption and walking decreases. Again, back to like shin splints, calf pain, heel pain, right? These people are going to have heel pain. Go, yeah, geez, I have this terrible heel pain. I can't get rid of it. Must be plantar fasciitis, right? Any pain in the foot is plantar fasciitis.
Yes.
Right? It's like,
Yes.
can't all be plantar fasciitis.
Nope.
Okay, so so maybe people can kind of understand from this, like if your weight is too far forward or too far backwards, both of those situations cause problems. Now, what do we do as manual therapists? We look at how these lines of gravitational structure line up, and we say, well, what's causing this person to lean too far forward or too far back, and is causing them to adapt and be stuck in that adaptation? And then we try to remove that, right? So, and there's the hard part is, so somebody might be complaining of heel pain. They might be complaining of, I have bad digestion, or I have a lot of gas, or I have bloating, or they might be complaining of, gosh, my mid back gets so stiff and I hold all my tension and pain here. And you would think, well, is the problem here? Is the problem in the abdomen? Is the problem in the foot? It's in multiples of those places. And a lot of it's not in any of those places. It's as the person's adapted from place to place, right? Autumn, you see this all the time in the clinic.
All the time. All the time. Yes.
Okay. So, right. And I guess that's what the take home message is for people, is understanding, look, there's a complexity there. And when you're going to a healthcare practitioner that only wants to focus in on a 6-inch wide box around the problem you're complaining of, and then discount anything else you might be talking about, that's not going to be helpful for you in the long term. So as for patients, I really want them to be informed and be able to demand, like, hey, well, I have this neck pain, and I have this knee pain, and I have this heel pain, and I want you to take them into account all together. And if your healthcare provider can't do that, maybe they're not as helpful as you'd like. and you have to seek somebody out.
It's hard, right? Because the way the medical system, at least in the United States, is set up, it's, where do you hurt? And then that's, because whether it's litigiousness of, you don't want to have too much stuff because then it broadens your liability to your patient or whatever. But, where you hurt, where your initial complaint is, that's where they're restricted to look at. Right. And so in a way, we're pigeonholed from the first time, where a lot of these symptoms don't come up until later. You've already been whacked, but because of those signals have to degrade a little bit further, a lot of the symptoms won't show up until later. And you do need to treat the entire body to be able to get those areas to resolve. And so you might have to look outside the traditional medical system to find that kind of care, just because it's set up to not help you that way.
And insurance. Insurance only wants to pay for one thing at a time, and they want to maximize their dollars. So if you have 5 complaints, that's 5 visits.
Yeah.
They make more money. So
And not just health insurance, but like car insurance, right? Like if you broke your shoulder or you broke your arm, that's all they want to treat. And yet your whole body got smacked around in that accident, right? So, it's in both,
yes,
both that I see.
exactly.
So,
So then just to summarize, posterior shift increases heel loading, sacroiliac strain, and reduced subtalar or ankle adaptability. Your ankles become stiff, right? And these aren't posture faults. There's nothing someone like, oh, I went to the physical therapist and they taught me posture. That's wonderful. But you can't teach this stuff if the body part is stuck. It's not a teachable event. These are adaptive survival strategies. Your body has gone, look, I'm in a certain place all the time, and I'm going to harden down to that. And unfortunately, I'm going to steal from Peter to pay Paul. And at some point, Peter wants paid back. And then that's when you go to the doctor and say, I have SI joint pain. And they're like, oh, let's take an x-ray. Let's take an MRI. And it may have nothing to do with that, right? I mean, that's the whole problem.
and we hear that all the time from patients too. Well, they took an MRI, there's nothing there. Yeah.
Yeah, we looked at the MRI. It's negative. It's all in your head. Oh, thank goodness. I'm just crazy. So
Very helpful.
Yeah, very helpful. Thanks, Doc. I'm glad I paid the
Yes.
$400. Okay, so
What can we do about it?
Yeah, what can I do about that? Like, here, take these opioids.
Oh,
Great.
yeah. Sorry, but I meant like about is there something we can do about our posture?
Yeah, exactly. Well,
Adaptation. How can we become more adaptable?
yeah,
And
so let's kind of get into that, right? So the first thing is to be able to recognize where you see things going wrong. So for example, let's look at walking. Walking is the ultimate adaptation test, right? So if you would either videotape yourself walking or watch yourself walk towards a mirror or something and just look for some certain things. Does the head balance over the spine, or is it off to a side? Is the person walking like this, right? Or are they in the center? Is the pelvis balancing over the legs, right? Does the pelvis do this, or does the pelvis move to one side? And then here's a really important thing. Most people know this. As soon as I say this, they'll recognize this, that the opposite arm moves, like say with your left leg, your opposite arm swings with that opposite leg, right? Opposite arm and leg swing together. If you see an oddity in the swinging of an arm, it tells you about how well or not well the opposite lower extremity is moving. Is it adapted? So below T6, and T6 is about mid-chest, spinal segments rotate opposite to motion above during gait. In other words, the upper and lower bodies, right, are supposed to swing opposite. If your hips are going one way, your shoulder girdle should be going the other. And so if you watch yourself, and a lot of people will see this, they'll get the sprinkler, where the sprinkler doesn't go back and forth evenly, right? They were great at dancing. They didn't even know it. So, but it's important. So if a person at home wants to take a look at that and just go, oh yeah, gosh, now that you point that out, yeah, I have kind of noticed that. I just didn't know what it meant. And hopefully now people will start to understand, yeah, this is what it means. You have a problem here or here. And the problem is if one region loses motion, another region gains motion and has to work harder. And then this is what we call a recurrent strain pattern. And I do this all the time for patients to help them visualize what they see going on with their body. Is I say, okay, lay on your back. And then I want you to take one leg across your body and see how far it goes easily. And then take the other leg across your body and see how far it goes easily. And everyone goes, oh, yeah. One leg will go, and they're going, oh, my hamstring, my glute, it's like tight. I need to stretch. And the other side, they'll go, whoa, look at that. And it says, yeah, there's the side that you can go to easily, the direction you're adapted, and the direction you can't go, right? What your adaptive loss. And so that's a great way to say, well, guess what your home program is? Whatever you can't do is what you need to stretch. Now, old injuries really feed into this, right? The body never really forgets prior strain patterns, and tissue memory influences how loads travel through the body, how the muscles fire, like what order they do, how hard they fire, and where stiffness accumulates. Now, how muscles fire. I want to point this out, that if your muscle won't turn on, for example, the classic is people go to the physical therapist and they say, oh, the physical therapist says my glutes aren't firing. Well, first off, you walked in the door and you didn't fall down. So your glutes must have been firing pretty well for that to occur. And so in some ways, a lot of the healthcare practitioners, and maybe they recognize it, maybe they don't, I can't speak to that, but they still describe it in a certain way. It's like, hey, I need to do these strengthening exercises. If I just strengthen it up, well, you can't strengthen a nerve. If the nerve doesn't fire right, the muscle doesn't turn on. There's no changing that, right? That's part of the OsteoSignal, bioelectrical. The nerves have to get the other signals, the biomechanical and the biochemical, to fire properly, right? If you don't have the right amount of hormones, it doesn't fire as much, right? If your mechanics don't work just right, then the nerve's never told, hey, time to fire. And if it's not given that signal, doesn't fire. And no amount of practicing that can change that effect. It's like, well, if it's stuck or still not getting the signal, you doing clamshells is not going to change that fact. Okay. Now, on top of that, we want to see how muscles fire, where stiffness accumulates, like where has it gotten stiff? That's my leg test for the patient. Not all bodies respond to force in the same way. So a lot of people will say, well, this back pain runs in the family. Maybe, but not every one of your kids has your exact physique. So physiques change how it occurs. And adaptive capacity matters. For example, I have patients, and sometimes you have twins, and one person will have all sorts of problems, and the other one, they're like, hey, we're twins, but this twin's doing just fine, and this one's broken and has all sorts of problems. Then you find out, oh yeah, this is the twin though that fell and rolled down halfway down the mountain.
There's always a story.
Yeah, there's always a story in there.
Yeah.
So, okay, so, and one of the things is I would hope for people, I would hope that people would read this or listen to this podcast and then go, gosh, I really want to find somebody near me. And one of the things we do is we list the practitioners on our website who have taken these classes and should understand this and might be able to help patients with that. So that's one of the things we offer so that people can find therapists however close to them. We don't have people everywhere, but we're trying to expand that. So
yes. And if you're interested, if you're listening to this and you are in that physical therapy space somehow, massage therapist or any, hands-on kind of therapy practitioner, we encourage you to visit Neal's website, pursuitpt.com, to look at his classes and take some. Start your journey and learn these amazing principles that can really help your patients benefit.
Yeah. Or if you're a patient out there, ask that person that you do go to, ask them to come and take a class and say, hey, why don't you go take a class and learn some of this stuff and then apply that. I'd love it. Yeah. So
great idea.
Yeah. Thank you, Brent. So we train people to identify your adaptive posture, find where the motion is lost, restore the minor motion, and then rebalance that gravitational alignment, get things back on top so they can move, forward and backwards and side to side on top of your vertical line of gravitational support. Also retrain walking efficiency. So we want to do that statically in standing or sitting, right? That's a very important thing. And then so much about how you sit at a desk or how you drive your car speaks to that. That's not entirely static because you're pressing the gas or doing things with the mouse, but also your standing and / walking, efficiency. We want to make you highly efficient because that's where people develop a lot of these problems. And then pretty soon they can't do the activities they really like to, whether that's hiking or running or biking or whatever. So, and that's what we really offer to manual therapists so that they can help their patients. And we want to spread this all out there. So we have to educate the public. We want to educate manual therapists or people who might want to become manual therapists. So in encapsulating this, your posture is a story, your walking pattern is a history, your pain is a signal, not necessarily the source. With the right assessment, we can restore adaptability. We can reduce your effort. We can improve your resilience, like shortness of breath. That will go away. So health is not symmetry. Health is adaptability across signals, biomechanical, bioelectrical, biochemical. Build up too much inflammation, that's a problem. Not get the nerves to fire properly, that's a problem. Biomechanically, not have minor motion and not have the joints be able to find their optimal positioning and movement pattern, that's a problem. And those are all problems that can be addressed and fixed. So
awesome. Is there something, so you mentioned that walking is an adaptability test?
It is.
Correct?
Yes.
Yeah. Is there something that listeners could do on their own to kind of help make that, make them more adaptable? Does that make sense? To kind of give them, better minor movement, help them, if they notice, they do that mirror test where they walk towards the mirror and they notice different things. What is there anything that they can do on their own
Yeah,
before seeing a manual therapist that would help them? I don't want to derail the conversation, but I just wanted to see if there was anything listeners could do, right now to improve their minor movement, their adaptability, things like that.
exactly. So we were kind of talking about like, where do people collapse? And let me move this back out of the way. Where are people collapsing? So for example, if they're walking, my camera follows me, and they see that they're side bent to one side, right? Well, they might as well sit down. And then they see that whichever side that they're falling towards, like for example, if you're walking and you do this, and then but you never quite go back to the other side, the side that you're stuck towards, right? The side that you're stuck towards, that means things are tight on that side. Now, maybe it's your side, maybe it's your front, maybe you have poor posture to the front. That means that you need to do stretching on that side. You need to stretch that side out. Now, maybe a foam roller there, or even a foam roller on the chest or on the back. Just looking at those, what body part is shifting and stays shifted and never comes back to the other side? You have to, whatever is pulling you that way, you have to loosen it up and move it back towards the other side. So there's a lot of, and then like I said, like the leg test across the body, you'll very quickly determine which hamstring, calf, glute, lat, back muscles you need to stretch. And then there's a lot of like yoga poses and stuff where people take their feet up as high as they can, up over their head, or they try to lean back over, say, a gym ball or something. And some people are doing that kind of stuff, but just making sure that when you go back over the gym ball, can you go left? Can you go right? And whichever way you have the hardest time doing it, you need to do more of that one, right? So don't do what is easy. Don't do what you can do. Do what you can't do.
There you go.
All right.
And that brings us back to the pain is a liar discussion, right? Like if you're stuck forward, this way, and this is your front of your body, you're probably going to have pain on this side,
right,
on the back.
Right.
You're going to have it between your shoulders and on your low back. And remember, don't stretch where you're you're going to be tight long and tight short, right? But we're talking about stretching the tight short.
Exactly.
So, yeah.
Well, and it won't hurt in the front in your example, because that's not being pulled on. What's being pulled on is these muscles in the back that are playing tug of war, going, we're losing. Yep. And they're going to complain about losing, because the front side's going, hey, we're winning. We don't have to complain. Yeah. So entirely, the pain will be in exactly the wrong area. And then everyone will, and pain being a liar, it often means that, and so for example, in that example, abdominal things will be the cause, but even like say the glutes. So you have back pain here, but the glutes are lower. And so we always say pain is opposite of dysfunction. Well, if the pain is here, does that mean above it? Does that mean below it? Does that mean on the opposite side of the body in the front? If it's on the left side, does it mean on the diagonal right side? Yes. You have to look at all those other possibilities and say, which one of those doesn't normally tell me that it hurts? That doesn't normally tell me that it hurts. But when I poke at it, I go, oh, why is that sore? That's what we call a sign, right? There are signs and there are symptoms in medical evaluation. And a symptom is what the patient experiences. A sign is what the practitioner can elicit. Well, if the patient knows some of the tests, they can elicit those too and go, when I poke here, it really hurts. Well, get a squishy ball and lay on your psoas in the front on the opposite side. Or that's why, like, say, people will have low back pain and then they'll go, oh, I did these McKenzie extension exercises. Right. You stretched the front by doing those extension exercises. And yeah, my back pain went away. It's all because of the disc and stuff. Like, it's the tight things in the front. And I will point out that the psoas muscles attach to the discs on the sides right where they herniate. Just saying.
Yeah. So I just wanted to point out that, we're talking about maybe stretching, and people listening, you might be like, well, duh. Okay, sure. But what I really liked about this discussion is that you're pinpointing, where to focus your efforts so that you get the maximum benefit. It's not just doing yoga or just stretching, right? You have to pinpoint, like you were talking about, where the pain is. And then you have to look, like you said, above, below, in front, behind, left, right, to take care of those issues. So people listening, this advice should really help you be able to pinpoint where things are going wrong to improve your posture and help you become more adaptable.
Yeah.
One thing I like to tell my patients as a general thing too, to help restore minor motion, especially on the spine, is to crawl. I have them call, 1 to 3 minutes, 2 to 3 times a day when they've been sitting at their desk, or when they've been, doing one-sided sports, and just to get that minor motion between each of the spinal segments. That seems to help a lot. And some of them are like, oh, I thought I had to come in for an appointment, and I've been calling, and it feels like it's doing a lot better. I'm like, great, I'll open up that slot for someone else.
Perfect.
So that's one thing I like to do. And not all patients can crawl, but a lot of people can. So that's one thing that helps too.
Well, and then, Autumn, what's your website so that patients can go look at that as well?
What is my website? Restorationmanualtherapy.com. Sorry.
I was about to jump
I don't
in
go to it very often.
Restorationmanualtherapy.com. Okay.
Yes.
All right. Perfect.
Yeah, because Autumn has some exercises there featuring yours truly doing what are called exercises called CARs, right? That help with
1 + 2. Yeah.
minor movement, I'd say.
Yeah.
And
Well, it
I'm
uses
just-
the
I'm
major
kinda-
motions, but then because of
Okay.
the way you do it, it restores some of the minor motion. It doesn't let you
Okay.
lose the minor motion.
There you go.
So controlled articular rotations. Very good at not hurting someone. So they're very gentle exercises, and it just uses the available range of motion, but right at the edge of the range of motion, so that people can pull just a little bit, as opposed to doing major stretches or something. So those are very useful.
Yes.
And Neal, you
Another thing
have
to do.
quite a few exercises on YouTube and stuff too that address a lot of those. Like if you hurt here, this is where you can stretch. Where is that? That's on your YouTube channel, yeah? Or is
It's
it
on
on
the
your
YouTube
clinic
channel.
website?
Yeah, and if you there are links from my website. If you go and look at the stretches and stuff and the exercise I have connected to my website, it takes you to YouTube where they're all stored, and then you can see it. Of course, YouTube's a little funny because they have the most popular ones show up, and there'll be like 5, and people go, "You only have
Yeah.
5 things on there." There's another little tab up there, and then if you click that second tab, the list will be on. It just go off the page.
Yeah, huge. Yeah. And your clinic website is pursuitpt.com.
Correct.
I go
Yeah.
to your website more than mine.
Yeah.
It's where I sign up for classes. So
Right.
yeah.
Right, and that's where we have that. So, yeah, this is a great discussion. And then I do have a patient infographic about how your body adapts that I was going to give to Brent, and he's going to attach it to this.
Sure, I'll post it up here so everybody can see.
Yeah.
Great.
And we'll put it online somewhere where you can click. And do you want them to be able to download it?
Yeah, that would
If
be
they want
great.
to?
So
Yeah,
they can
okay.
kind of just see like a breakdown of what it is we talked about, so that again, we want to educate patients so they can educate medical people. And medical people, right? There's plenty of manual people out there. There's plenty of manual therapy people out there that would go, "Hey, let me keep this by my, that reminds me. Let's keep a list." So,
All right.
and then, like I
awesome.
said, we have patient resources. Say you live in a part of the country that is nowhere near Seattle or nowhere near Missouri. Well, there might be a practitioner that we know of close to you, or a practitioner that's actually taken the classes. So, I mean, that would be ideal, because we have testing of our various levels to make sure that people are up to snuff, and they really know what we expect them to know. So when we say that this person's taken this class, or they've attained a certain level, are they a practitioner, a clinician, master clinician, then we know they've really attained a high level of treatment ability.
Outstanding.
All right. So thanks for listening to OsteoSignal with Neal O'Neill, and Autumn Mayberry joined me, Brent Mayberry. Thanks for listening, and you could always come back here to look for more podcasts.
All right. Thank you.
Thank you.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neill.